Dr. Soon Ing Shian. She is currently a pediatric consultant in the Department of General Pediatrics and Neonatology at RIPAS Hospital, Brunei. She is practicing as a general pediatrician and a pediatric gastroenterologist. Dr. Soon has been an active member of the Medical and Health Research Ethics Committee since 2014 and is currently the Deputy Chairperson for MHREC since August 2022. I now invite her to give her talk on pediatric ethical issues, a perspective from Brunei.
Thank you very much for the kind introduction, and good afternoon, everyone. First of all, I would like to thank the organizing committee, especially Prof. Joseph Roy, for giving me the opportunity to share our experience from Brunei. I do have a disclosure. I'm not an expert in ethics. I'm just a clinician. So I have a lot to learn from these 2 days conference. How do we move slide? How do we move to? Oh. Maybe extend that. Oh, okay. Thank you. So this is the outline of my talk. I'm just going to briefly introduce Brunei and its healthcare services. Oh, sorry. And then I'm going to go through a few ethical challenging cases that we face in Brunei. For those who don't know where Brunei is, we are located on the northern part of Borneo Island in Southeast Asia. It's a very small country. We only have a population of less than 450,000, so very small compared to where other speakers are from, and our surface area is about 5,765 kilometers square. There are about 4 government hospitals in Brunei, and RIPAS Hospital is the largest or the only tertiary center in Brunei, and we have about 1,260 beds. There are 3 private medical centers, 16 health centers, and 10 health clinics. Brunei actually have a national healthcare system where government actually provides free medical services for its citizens. In addition to that, for treatment and facilities that are not available in Brunei, the government will actually coordinate and cover the cost of sending our citizens overseas for this treatment. So we are actually very privileged. So pediatric service at RIPAS Hospital is actually located in the Women and Children Center, which was officially opened in 2015, which is less than 10 years ago. We have a total of 203 beds, including NICU, SCUBU, PICU, as well as general pediatric beds. There are only 35 pediatric doctors, including specialists, medical officers, as well as senior medical officers. So we actually is a very small team. Oops. Next, I'm going to go through a few challenging cases. Not that I have answers to the questions, but I'm going to post it out there. So the first case is a 3-year-old boy who was diagnosed with adrenoleukodystrophy when he was about 21 months of age. Screening for ALD was actually done when his older maternal cousin was diagnosed with cerebral form of ALD. The maternal cousin deteriorated quite quickly and passed away when he was 4 years of age. This child was diagnosed with autistic spectrum disorders shortly after the diagnosis of ALD. At that time, the MRI brain was normal. Parents were understandably devastated with the diagnosis of ALD and wanted the son to have bone marrow transplant. They don't want the son to undergo what have happened to the cousin. So what is X-linked adrenoleukodystrophy? It's a progressive disease resulting in the buildup of very long-chain fatty acids in the nervous system, adrenal glands, as well as the testes. It leads to long-term coma about 2 years after nervous symptoms develop, and of course, eventually death. There is currently no cure for adrenoleukodystrophy, and the treatment is mainly supportive, including steroids for adrenal dysfunction. So bone marrow transplant may be beneficial when done early in the course of the disease when there's no neurological deficit. Next case is a 4-year-old boy who was diagnosed with Hunter disease or mucopolysaccharidosis type 2. He was diagnosed at 9 months of age, and this was done through MPS screening due to global developmental delay and a very strong family history of mucopolysaccharidosis. Parents heard about enzyme replacement therapy for Hunter's disease and is asking if this can be done can be made available for the son. So X-linked Hunter disease is an X-linked lysosomal storage disorder characterized by progressive storage of glycosaminoglycans and multi-organ impairment. Of course, there's also currently no cure for this, and enzyme replacement therapy has been shown to improve urinary glycoaminoglycans level as well as the liver and spleen size. However, there's no evidence of clinically meaningful benefits such as prolonged survival, improved quality of life, pain reduction, or better physical function after treatment. It does not penetrate the brain, so therefore unlikely to prevent any neurological disease. It involves a weekly intravenous injection, and it costs about $500,000 per year for a child who weighs about 35 kilo. Our ethical dilemmas here is when healthcare is free and resources are limited, who gets to decide who gets what? Should the physician be the sole decision maker? And should invasive procedures be recommended for patients with lethal conditions? So for the first case, bone marrow transplant is not available in Brunei, so the patient would have to be sent overseas, which would incur a huge cost on the government. In view of uncertain outcomes, especially given that the fact that the child already started to have neurological sign, should bone marrow transplant be offered to this patient? For the second case, given the cost of the enzyme replacement therapy, should it be offered when there is no evidence of clinically meaningful benefits? So when healthcare is free but resources are limited, who gets to decide on resource allocations? Of course, healthcare allocation should satisfy two main ethical criteria. Allocation should be cost effective. It should maximize the health benefits of the population served. And by spending on therapy that is not cost effective, it produces fewer benefits than would have been possible for a different allocation. And secondly, allocation should be equitable or just. So it should be would resources spent on one patient deprive of others in the society? The enzyme replacement for this one patient, are we able to spend those for a clinically evidenced vaccine for the whole population, for example? So for this, our approach to such ethical dilemma, we actually propose to meet with the parents to hear their concerns and reasons behind their request. Of course, for the clinicians to find out what is the clinical evidence behind the therapy that is requested. Is the therapy actually effective or not? We do not have clinical ethics committee in Brunei or in the hospital, so usually we discuss among ourselves to get a consensus before making the recommendation to the Ministry of Health. And for drugs that are not listed in the National Standard Drug List, we will actually need to apply for permissions from the Drug and Therapeutic Committee, where clinical evidence and cost effectiveness of the proposed treatment will be evaluated by clinicians as well as pharmacists. So back to the case. So for the first case, patient actually had bone marrow transplant overseas under Brunei government sponsorship, father being the donor. He actually had 100% engraftment 1 month post-transplant. However, unfortunately, he actually passed away from severe infection 16 months after transplant. For the second case, a 4-year-old with the Hunter disease, hormone replacement therapy was not recommended, and he continues to have close follow-up in the pediatric clinic. Next, we have a 2-month-old who was presented with conjugated hyperbilirubinemia and pale stool. Liver biopsy was suggestive of biliary atresia. He was recommended for further investigation and Kasai procedure if biliary atresia was confirmed. At the time of diagnosis, HIDA scan, cholangiogram, or Kasai procedures were not available in Brunei, and patient would actually have to go overseas. Of course, because patient being a citizen, it would be under the sponsorship of Brunei government. After extensive counseling, parents actually refused to go overseas and refused surgery even if biliary atresia was confirmed. Kind of a similar case is a 1-year-old girl with tetralogy of Fallot and worsening cyanosis, and it's recommended for surgery. And again, the surgery is not available in Brunei, so it's recommended to go overseas for the surgery. Both parents actually refused surgery and actually defaulted appointments in the clinics. Medical social worker and child protection team were consulted, and a court order was obtained to ensure parents were compliant with our recommendation. So in both cases, surgical procedures were not available in Brunei at the time of diagnosis, and parents actually needs to bring the child for further evaluation and treatment overseas. As we mentioned, because they are both citizens, medical expenses overseas will be fully sponsored by Brunei government. However, when parents refuse further evaluation and treatment overseas, what can we do? Who will actually bring the patients overseas, and who will consent for the procedures overseas? So in cases where parents actually refuse recommended investigation and treatment, communication is key. We should try to understand the reasons for the parents' reluctance to consent. Is there any misunderstanding related to the recommendations made by the clinicians? And if parents still refuse, is there any alternatives that might be acceptable to the parents, while at the same time guarding the best interest of the child? Brunei is well known for the close-knit family structures, and extended family members are often involved in the decision-making of the child. It can be good or bad things. So if it helps, we do invite, parents actually can invite them to the family discussion, but sometimes it can be a hurdle to the decision-making as well. So if parents still refuse after extensive counseling, we usually refer to the medical social worker as well as the child protection team. And what can they do? So what legislation do we have in Brunei for parents who refuse medical treatment? So the Children and the Young Persons Act is the only key legislation that protects children under the age of 18 years in Brunei. And it is actually enforced by the Ministry of Culture, Youth and Sports in Brunei. And a child or a young person in need of protection would actually include someone who actually needs to be examined, investigated, or treated for the purpose of restoring the health, but his guardian neglects or refuses for him to be examined. To be honest, actually, in a clinical practice, we almost rarely or seldom needs to go through this, because actually our social services is actually still quite infant in the process. So back to the case. So patient eventually passed away from complication of liver failure at 2 years of age, and our tetralogy of fellow overseas surgical correction fell through as parents continued to refuse treatment overseas, and there was no system in place to bring the child overseas without the parents. And of course, patients eventually passed away. Next, we have an 8-month-old girl with end-stage liver disease. It's a known case of biliary atresia, and Kasai was actually done at 3 months of age. There was a delay due to travel restrictions during COVID pandemic. So living-related liver transplantation is actually recommended for her. So we started to screen the parents as potential donors, and unfortunately both parents are quite obese, and they were both diagnosed with type 2 diabetes during the screening. So mother informed us that a colleague or a friend would actually like to be a liver donor for her daughter. So in Brunei, so we started sending patients for pediatric liver transplant about 10 to 15 years ago, and it's not available in Brunei. We will actually send them overseas. And to date, we only have parents as donor. So when this comes to us, what is the possibility of having living unrelated donor? What is the donor's motivations for giving an organ? Is it emotional connection to the child or the parents? Or is it just wanting to do good? So is the donor informed of benefits and risks involved? And is her decision free of coercion? Is the questions that we ask. So in this case, we actually set up a meeting between the clinical team and the potential donor without the parents. She was informed of the potential benefits and risks of being a donor and invite her to ask any questions. We actually give the donor time to think about the donation and to inform us directly if she wants to proceed with the donation. And of course, if she decides to proceed, an independent donor advocate would have been appointed to protect her. So she never actually contacted us after our meeting, and parents could not find a liver donor, and this girl eventually passed away from complications of liver failure. Lastly, I'm just going to kind of briefly mention, I think we have heard enough from this morning about whole genome sequencing. I guess it is now widely used in children with unexplained developmental delay and also disability, as we heard this morning. However, our dilemma is we do not have a geneticist in Brunei, and we also don't have genetic counseling available. So when should it be recommended, and who would actually do the pre-test counseling? Consent should actually include potential risks and also limitation of the testing. And how do we interpret the results? And who would actually communicate the results to the parents after we have the results? So in summary, in a free healthcare system, we are faced with different ethical challenges. And a decision on healthcare resources needs to be cost-effective and equitable, as mentioned. And for parents who refuse investigation and treatment, communication is key. But in Brunei, it's still very hard for most of us. Where do we go when the parents actually refuse life-saving treatment? And we think we should move forward to have a clinical ethics committee where difficult cases are actually discussed and also consensus obtained, rather than having each individual clinician taking the burden. So I would like to thank all my colleagues at RIPAS Hospital who actually contribute to some of the cases that I mentioned. And thank you everyone for your attention.